Take the moderator's prerogative to kick off with a question or two. I sadly just realized that by some people I'm a young old person, so I'm a little I'm a little depressed, but I'll try to stay positive. No, seriously. One thing I want to say is I do see this panel and Marianne being representative of our older adults as sort of establishing the framework for the whole day. Hopefully we're keeping her in mind, and even though she's, I think on the high end of completely capable and independent, without air quotes, I'm hoping that we can help the day, sort of put bookends on the day of what we're trying to achieve and what our challenges are. So based on your two perspectives, I would ask you to say if there was one thing you could change about the older adult experience with communication in health and community. And I think Bernie said a lot about how social determinants of health really are perhaps a bigger factor in what yields success or improved health and health outcomes. If you could just change one thing, and I'm not saying that you know necessarily how, but what would that one thing be in the experience for older adults? Marianne, you want to start off with that?
Something I didn't mention. Right now, and it'll change, I'm sure, but the automated systems, as I often make phone calls because looking things up on the net are so hard, and the fake voices, especially when you're waiting for 50 minutes for somebody to come and you don't want to have to stay in your house all day if you say, call me back. I recently had to wait 55 minutes for the phone to answer, and 55 minutes later it was answered. But within that 55 minutes, there was an absolutely awful voice. After I'd gone through about 15 minutes of that voice getting me through pushing these buttons, that said exactly the same thing. And of course didn't mean it because it was a fake voice. That by the time the person answered, I couldn't really remember why I had called. And so we went through confusion around, oh yeah, because I was by then working on my computer and doing 3 other things. And number one, having to go through all that to be able to say, call me, and I'm staying on the line because I don't trust you to call me back, to then hearing this voice that didn't say anything and was irrelevant, caused confusion rather than anything else. And that was, I was more or less paying attention. I was doing work. Fortunately, I write notes, so I went back and said, let me find my notes. I know I called you for a reason. That's mine.
Okay, so I'm thinking of having worked with our parents who are older adults in the healthcare system, and I would really hope that all of them would slow down. I know that healthcare providers are extremely busy and billable hours are important, but just trying to manage through and help another person through their healthcare events, as I have in the past 5 years, I just wish people would slow down and meet the patient where they are, not where the clinician is. Not where the provider is, but where the patient is, in getting them help for that next day, just to make it for that next day.
Thank you. So I'm going to ask one more question for now and then turn it over. So I don't know if you do tent cards, or is that how you get attention? I'll look and see. But thinking about the individual and the community in which they live in the health system, are there models for bringing the range of perspectives together? And if you have to balance a community model or a medical model perspective, which vantage point might have the bigger impact in considering how we really start to bring the perspectives and the level of communication across those environments together?
For me, no one size fits all. And I've read articles in New Yorker and other places about, people trying to help with big data. We've got all this information. How do we cull it and use it? Right now, we don't seem to be able to cull it and use it very well. And it appears that when it gets used, it's more making it bigger rather than being able to use it individually. And as you said, each of us is different, and the people that we're working with is different. And that same data should be able to help us fine-tune rather than just say, here's the way to do it, and not really understand where the individual differences are important. And on the community side, I just say, I've learned, because I don't know about models so much, but the village movement, and that's helping neighbors age in place, and it's just one kind of model. But it fits within a system, and we're understanding in Montgomery County, which is where I live, is it's only taking care of a small component. And you'd think, well, you're supposed to take care of all this, but taking care of that one component helps resources and other things that this model is helping to be spent in other areas where there are fewer resources and perhaps more needs. And so even what is a model may be tempered by where you are, what you have, what's available, what people can do.
Well, I was just thinking about the patient-centered medical home model. Still there?
Yeah, it's red. So-
Okay, good.
Oh, okay.
Yeah.
But if you don't have to look at me because I
Okay.
can't, your voice isn't projecting good.
Well, I was thinking about the patient-centered medical home model where you have a patient-centered medical neighborhood as well, and integrating community services and services for the aged into that model would be a great step forward. So, and then maybe even wrapping that around with a health literate organization, so combining them all for optimal services.
Great. So Bernie's informed me that we can have people step up to the mic. So I see Kathy's card up. So do you, Katina, sorry. I read it quickly. Do you want to come up? Okay, that's fine.
Thank you both for your comments this morning. I'm Katina O'Leary from Health Literacy Media. So just two thoughts. Marianne, I really appreciated your perspective, and I'm also an only child, and I'm dealing with a mom who just lost a spouse. And one of the comments that you made about this idea that you have to be independent is something that she says all the time that I make meaning from and feel guilty about. And so hearing you say it up there in a way that it's a very sort of healthy approach was useful. So I really appreciate that connection to sort of health literacy and empowerment and independence. So thank you for that. It's personally very helpful and I think a useful approach. Amy, I had a question for you, though. So you talk about sort of interventions being limited, but this idea that cognitive decline is a real important driver of what's going on with this, and it accounts for so much of the change. And so I'm just thinking about whether you have ideas on directions for promising interventions, knowing that cognitive decline is very much what drives this, and that's not the area most of our interventions have focused on.
Thank you, Katina. So I have a couple of thoughts about that, whether you're using universal precautions or teach back, whatever intervention that is tested and being used at that time with that person. I think the key, as I said earlier, is slow down and account for that cognitive decline and be very clear. And teach back in that moment can be really great, even if you're just trying to solve a small problem, not necessarily having a chronic continuous problem, but in each encounter, in each exchange, having clear communication that's at the pace of the person rather than just moving along so quickly. So that would be my number one.
So I think Marianne wants to chime in on that as well.
Yeah, if I could, at least an impression, more than an impression, but because I've been in the last 2 years at a number of hospitals, and one of the things they all have are social workers, and I've gotten to understand the social worker at the infusion center the best, which I think relates to your question, in that she meets all of the patients at the infusion center, their families, or whoever comes with them, and sort of deals with us where we are. And while she also offers a bunch of different services in the kindest way that you almost don't know that they're being offered. We'll get information. I've sort of half heard her what sounded like helping somebody that was getting kicked out of their home to refer them and help them deal with a system so they could stay in their home while they were getting their cancer medication. Somebody else where the family wasn't really sure what to do that. Just a whole variety of things. I like to eat. I haven't always been able to do it, but we've talked about food in Silver Spring. That's where I was at the time. And so it's similar, I think, to what you're talking about of how to meet somebody where they are. And I will admit, when I met her and met people in that position several places, I had discounted that they could do anything for me, and I was very wrong.
The social worker in me is so happy to hear that. So thank you very much.
Okay, Kim Parson.
Good morning, Kim Parson, roundtable member representing Humana. And Marianne, my question is for you. You talked a bit about your trusted sources of information, and I'm interested in how you determine what your trusted sources of information are.
Besides the ones that give me the answer I want. Actually, I brought one. It's been my primary care doctor has been a major source. And part of that is he is somebody that likes to understand a broad variety of things. And so he's referred me, and he knows I like to read. And so he's referred me to things, in fact, said, don't read this version, read this one, it's in English, and it'll tell you the same thing. The other's just medical language and won't give you more. So I've done that. When I got into chemotherapy again, they provided me written, as well as telling me, they provided me written information. I had a friend who gave me a bunch of things, which I think was from the Cancer Institute, of how, when you go, what to look for, of how you're responding. So I've taken questions from a number of different sources of professional organizations that sounded reasonable. So I got initial questions from things like that. On the net, I look through Google, and if I can find something, I'm often looking for diets. I've been told about it, and I don't remember, and I know that there are more options. That's one of the places where I look for options that give me what I want, which can be what cereals can you eat. You don't list the one I like, so I'll keep looking. I find it and I eat it.
So can I just, because Marianne and I have sort of talked as she developed her presentation, and you mentioned one of the things about the doctor that made you trust him and value him that you haven't mentioned, his availability via the phone and text, I think.
Yeah, that is true. My primary care doctor is part of what I would, from what I understand, is sort of a moderate-priced concierge service. But one of the things, so he has had a very good email system that I've been able to use. But one of the things, when I got sick last year, he gave me his home number and his cell number. And I have called him several times on his cell. He was at dinner, he was someplace else. And he talked to me then and worked me through some things. I also had one other doctor, because I react a whole lot to the preps you have to take, because I can't drink them all. They want you to do that in 2 minutes. And I sent an email through another secure system, and much to my surprise, because it was on Sunday, he responded. I think he actually called me back to tell me, what do I need to do to get through this? And so this is where some of the systems, because of the availability of the doctors, and I do trust my doctors because they talk to each other as well as find English ways to talk to me. And make sure, ask me if I actually listened to them instead of hearing just what I wanted to hear.
So Michael Wolf.
Thank you both. Actually, this is very much along the interest I've had, so I've been very much looking forward to this session. So I don't think it should come as a surprise. We've done a lot of work actually that kind of fell out of the systematic review, I think mostly because of what you exactly said. Where do you draw the line in terms of what is old, So we have a cohort study I was just going to make a quick mention of that has been tracking patients for 10 years since 55, but that probably falls out of things. But just as a one comment, because I do want to get to the cognitive piece, but also on the what to do about it, because it's actually quite impressive from what we've been learning how preserved health, as we're calling health literacy skills, and what we focus on is maybe not so much the, how well you perform on a test that I think many of us in the room probably don't like the TOEFL and the NVS and in the realm. I'll throw them all under the bus. But how you actually perform real world skills, like the complexity. And I think the challenge for us that we've been trying to figure out is, we don't want to just study what happens over time as you get older, what happens to your health literacy skills, but what do you do about it? And when it does come into the fact that, as your cognition becomes distracted across multiple chronic conditions and the need to I loved your just breakdown of everything that you've had to kind of deal with, and a lot of it makes us get frustrated with the healthcare system and how fragmented it is. So I probably would push back a bit. I don't think things like teach back or communication skills training has anything to do with, I think it's not going to help. I think what really needs to help is we need to figure out how to leverage technologies to some regards. We need to figure out how to really integrate or have interoperability among healthcare systems and health communication tools and whatnot. And I guess I just don't know if there's even maybe a good mapping to what services are currently in play that could maybe, from your perspective, be brought together in a little bit of a more cohesive manner, whether it be through, are there clever ways to get reimbursable services that actually would provide meaningful help to reduce the complexity of people who are dealing with more and more complex issues that are more and more fragmented. Sorry for that really kind of maybe abstract.
Two thoughts came up that I know. One, I know something about, the other, not so much. But a thing that I have found immensely helpful is note-taking. And it's one of the things Silver Spring Village offers. It's non-professional. There is training available, and Iona Senior Services in DC was the one that provided the training that we took. And we were just experimenting and I was the first guinea pig. Because what it helped doing is you had a neutral source. You've already talked about what is it you want to get out of your visit. What information do you want? What information do you want to give? And that person takes notes about it, but also makes sure that it's making sense. And then you get something written. And it was a process that, number one, I have needed, and that's the person then that reminds me about what else was said. The second thing is I learned from that how to prepare to meet with a doctor, how to make better use of the time. And I have actually had more productive meetings where I wrote down, this is what I want you to know, and the doctor looks at it, and then we just get right into it. So we've gotten good enough communication. The other thing is another name of a gerontologist, is that the right name? That apparently you can get for some specific things. You don't necessarily need them for a long time. But I've heard of several members in our village that have had more acute, more needs, and that have been able, and they had no one to really provide them, to hire somebody at a cost they could afford to help hear the thing. Let's talk through what options are and help them make some decisions. Then they're out of the picture, but could be called back.
Okay, I'm going to turn to Bernie. Oh, I'm sorry, Amy. Go ahead.
Well, I was just going to answer a little bit further from my personal experience, not as a researcher, but thinking about years ago when a friend of mine did her dissertation on the personal health record. And at that time, I had great hopes that we would have something about that functionally within our healthcare system. But in recent years, I've been kind of that health navigator for family members, and I've seen how that's become even more crucial, because communication between specialists is just that. it's really almost not. And if they are speaking with each other, I don't know that that information is clearly being communicated back to the patient. And as she was saying, so she hears some information from her encounter and then goes back and does her own research to find kind of what she needs to know to function in her world. So I would hope for integration of a personal health record someday.
Sorry about that, Amy. So Bernie, and then we're going to go to Rima, and then maybe ask the audience. Okay.
So I'm wondering, once again, about something we mentioned earlier today, and that was the social determinants of health. And what's really the impact of education, housing, transportation, food, neighborhood, community resources on the ability to really impact health literacy, both in a positive and negative way. Social determinants of health, to me, perhaps in many instances, more important than the clinical services that are delivered to the population. And in this circumstance, I would think that we need to think a little bit more about its impact on health literacy. So I'm just wondering about your response to that.
Yes.
That's good.
No, and what I would agree with you, your access to things and your experiences, I think, make up a lot of what then you can do. I mean, reading articles, watching TV, some personal experience. There was a woman, and I think it was a true story, trying to do something. No, it's the start of the program I'm not watching because it's on too late. The good girls, and there is the one woman who got into it because she wanted to help her child get some medical care, and she couldn't. She could explain it, and the doctor didn't listen, and she finally got the doctor to listen, but what she needed was very expensive. So she got in, let's go rob the store so I can have the money so my kid can get the treatment that's there. She was economically not good, in good circumstances. She had the brain power, she had the knowledge, she had found the right information, an unresponsive, in a useful way. The doctor told her the truth. You can't get this because it costs this much money and you don't have it. Not the best way to tell it, but it got a program going. And so her response was a legitimate response to what her choices were. But so I do think there are all of those things. You're in an area, and we know people, there are a lot of people that don't have access to computers, and they want you to fill in all these forms, and you can't do it because you don't have it. So there are a lot of these things that go on, the support you get from your community, the social worker that you talked about, all of those help the clinical side, I think, then work more effectively because you can interact with them more effectively.
So yes, the things that you're talking about are absolutely key. Those are the things that I call life. So outside of a clinical encounter, and we kind of went down that road for a little while, I would say they're even more important than a clinical encounter. And how to measure them, now you're talking about community research and longitudinal studies and even community-based participatory research, all of those things that take dollars and they take extra planning, and you don't have a captured cohort of any kind. You've got to create that within a community. And so that is where the real work begins. And I think it's actually more important to measure life than to measure the clinical encounter. So well stated.
So I didn't see Linda's card up. I thought you had put it down again. So, okay. So Linda, do you want to ask a question? Or Rima? That's fine. Rima, go. And then.
No, Linda had it up first. That's fine.
Go ahead.
Linda's worried about my standing. I just found out that I'm middle-aged again. So don't worry about that. Yes. I wanted to challenge the notion. You know, first I really should begin by complimenting both of you, laying out the terrain for us, you know, in a very wonderful way. And Marianne, most especially laying out the terrain that you have to traverse. and that is very burdensome. And Amy, for your very superb literature review. But I do want to challenge the notion that cognitive decline is the predictor of literacy or of health literacy. Educators will tend to disagree with that and point out the fact that it's really use that is the best predictor of literacy skills, whether it's health literacy or any other kind of literacy. So adults, for example, older adults do perfectly well, as do working adults on literacy tests, if indeed they have been actively engaged in the word, using the word, reading every day, working with numbers. So it's actually use. Michael Wolf and I have debated and discussed this for a long time. The cognitive scientists will talk about cognitive decline. Educators will talk about use of literacy skills as the best predictor. And while Baker's study is an excellent study, was very important in its time, it did use a flawed instrument, but more important, it timed people's response. And so when elders took the TOEFL untimed, they did fairly well, and they did much better. So there are mitigating issues, and I would just be very slow in absolutely linking cognitive decline to lower health literacy. And think about that, and think about the circumstances of people's lives, the timing, the burden that people have to face as a major influence and major importance. I thank you both for really superb presentations.
Thank you. Linda's going to go. I just want to add, we're having that same issue with, young adults and students now with all the ADHD. Everybody gets extra time. So I don't know if they're using that instrument now on the lower end of the age spectrum, but it would be a challenge. Linda.
Hi, thank you all both so much for your presentations this morning. Marianne, I have a question for you. We do a lot of assessment and we do research about assessments, and some of that research is to just better understand, the general populations of people with limited health literacy. So my question to you is, are there questions that your providers should ask you to help them prepare to work with you in a more efficient and effective way to help you communicate with them better? Are there questions they could ask you? One of the assumptions of some of the research is that, health literacy is kind of a static thing, but you've shared with us that it's kind of a fluid. There's a lot of fluidity in our ability to understand and communicate with our providers. So are there some questions that people could ask you to help us understand in a predictable kind of way the best ways for you and your providers to communicate with each other in productive ways?
Have to ask a tough one, huh? Because I spent a lot of time looking at what question should I ask. And thinking quickly on what I've been asked, especially with the 2017 when things, see, we didn't get rid of the cancer, it's come back. The thing that doctors have spent time on is trying to understand what's important to me. What do I want out of this? If we're trying to deal with something, because and part of this is filling out forms, but do you want to have medicines given to you no matter what happens? Are you trying to, be able to go on one last fling across the world, or don't you care at all? I mean, there's some things of understanding what's important for me living, however that is, that they have asked and has been important, and in fact has influenced, well, and they've told me sort of why, influenced what they have then done to try to better meet what I have said, my definition of life from here on out, what I would like that to be. So does that answer it all?
Do they ask you questions about your sense of your own cognitive abilities, your understanding of medical jargon? Do they ask you those kinds of questions, and would that help?
They I'm probably over-exaggerating, but they don't use overly technical terms. The primary care physician is somebody relatively new. He's been in the practice, but I've had him maybe 4 years. But he observed I asked a lot of questions, and he also asked a lot of questions. That's why he then referred me to English language things to be able to learn more while we talked about things. And so in that case, that's how he dealt with it. The other specialists at this point, number one, they do talk to each other. They aren't all in the same system. To some extent, systems may or may not take this away, but they all know each other. And that's probably, it helps because since they're what I consider good doctors, they know how to communicate. They have figured out how to get information back and forth, and they are willing to share. And when they haven't been able to, they have told me. So I'm probably not totally helping, but that's been my experience, which has helped.
What I hear you saying is that your providers are kind of doing their own evaluation of how much information you want, what level of information you want, and they're adapting to that, and that they've done a pretty good job.
I think so. And part of that note-taking maybe helped that on both sides, because the doctors also welcomed the note-taker, and in a few cases have said, where is the note-taker? Because they have found that we've kidded about how I do listen for the answer I want and how I ignore the other parts that may require me to do something. And the note-takers help make sure that we are communicating on both sides.
Okay, we have time for just a few more questions, and I want to let the audience participate. So Cindy, we've got 2 people at the mics, and if anybody else in the audience wants to get behind, we'll try to move through a few. Actually, and Tony's at the mic. So we have 3 questions teed up, and let's see if we can get through them. Go ahead.
My name is, excuse me, I haven't talked yet since morning. My name is Cindy Brach. I'm with the Agency for Healthcare Research and Quality, and I'm either emeritus or ex officio on the roundtable. And I first wanted just to share some data because we were talking a little bit about, what we know about the health literacy of older Americans. And Cynthia Bauer and I, in writing up a brief on the health literacy national adult assessment of adult literacy results, did break down the elderly category. And the issue brief is on health.gov called Americans' Health Literacy, Why We Need Accessible Health Information. And it really is quite interesting what a drop there is when we broke out the over 75 population. So when you look at the 65 to 75 population, you had 23% in the lowest category below basic and 28% in the basic category. When you get to the over 75, that jumped up to 39% in the below basic category and the 31% in the basic category. So, so you can see there's a precipitous drop. And then I compare that with what Marianne is telling us about the demands that are being made on her and the stack of papers she's bringing around with her and all the community that she has to help her, and yet, struggling through those voice messaging systems and all of that. And I get very disheartened because, we've talked in the roundtable a lot about the mismatch between the demands and the skills. And I think in this population in particular, it is just so striking how far we are from making those match. And the a looming problem with the aging of America as the demographics are just going to create larger and larger group in that older American category. So I'm really looking at systems level kinds of thoughts about how we deal with this. And Marianne, I think in founding the Silver Spring Village, you really, tried to isolate a gap and fill that gap, and did that with an array of volunteers. If you were going back to the drawing board in designing the village, is there anything else that you would try and make part of it? And I'll use Ruth Parker's magic wand to allow you to have more finances to do that, because I know you rely a lot on the small membership dues and donations.
And a few grants. We have been able to do that, unlike some other villages. The question again, see?
So, Matt, you have a magic wand to redesign the Silver Spring Village to try and address some of these gaps.
Their villages have different models, and we are the non-professional model. The group that designed the village initially we started with, we want to have some staff members to provide continuity, potential sustainability, and focus, while volunteers do most of the work. We did not want to have, which some other villages do very successfully, some more professionally trained staff, often in social work, that could provide other services. I think right now we're happy with our model for our community. And so I don't know that we would want to change that. I think I'm personally happy that we're now getting mature enough that we've evolved. It wouldn't have worked initially. Started with 35 members, we now have about 200. And we've evolved as the membership has sort of wanted it. And so I think the biggest issue is, which we'll find out because we're 5 years old, is being able to sustain that over time with a changing landscape. Because the needs, I think you're going to see something different in the health literacy as the 65 to 75, move up the 10 years, because the 65-year-olds that go note-taking with me, I'm 72, almost 73, they will put up with the computer a whole lot longer than I will. The 50-year-olds don't even think about it. And so there's some of the things around communications that I think may change. Eyesight, want to read all that, I don't know. But there will be some changes. Access, I think, will be more important, because if you don't have access to it, haven't used it, you aren't going to start typically at 75 to find it as your best friend.
Well, as a resident in the Silver Spring Village catchment area, I thank you.
All right, let's go to this microphone, please.
Stephen Thomas, University of Maryland, College Park. Dr. Rudd gave us a caution about the cognitive decline. And I would simply say there's another side of the coin. I hope it gets as much time in our discussion, and that's the empathy decline. There's a decline in empathy on the part of our providers. And we need to put that on the table in this room. All the burden cannot be on the patient and the neighborhoods in which they live. Thank you.
Thank you. Tony?
Hi, I'm Tony Sarmiento, and I'm president of the Silver Spring Village. We have a very active board, of which Marianne is a true representative, and as someone who chairs the meetings, I can testify that we have people who are deeply engaged. Just a couple thoughts. First of all, I appreciate the Academy for putting on this discussion. The villages, as I think a number of people have said, this is a sort of a bottoms-up movement that started probably about 15 years ago. And there are about maybe 250 to 300 villages that exist around the country. If not already operating, then they're trying to start. You may want to take a look at the research that's been done by folks at UC Berkeley or Mather Lifeways. And what you'll find is there's tremendous variation in these villages, both in terms of organization, capacity, number of members. But one of the things that's clear is that they also reflect because they all share a couple things. One is that they're supporting older people like myself, age in place in our communities, and they are largely reliant, at least in part, on dues by members. Then you can't help but sort of go to the next step, which is to realize that they also represent or indicate the cumulative disadvantage or advantage of various neighborhoods. So when you look at who's in the villages, they're largely white, middle class. You could see also there are fewer villages in rural communities as well as neighborhoods that struggle. And so I think one of the challenges of the Village Network, and there is a national organization called the Village to Village Network, the challenge is whether these kinds of organizations can not only be launched, but also sustained in communities that are either dispersed or have fewer resources. Also, with the reference to ageism, I think it might be worth, if you're not already familiar with some of the latest efforts being done by a number of national aging organizations, research that's been done by the Frameworks Institute, based here in Washington. They've published 3 reports. And a similar report out of Canada by the Rivera Group, I believe it's called. I thought both those reports really get at and highlight the importance of challenging the internalized ageism among older adults themselves. Mm-hmm. And so perhaps these kinds of things could inform the continued work of this effort. Finally, I also would just want to say, as someone who has followed the adult literacy research since the early 90s, beginning with the National Adult Literacy Survey and the various efforts that have followed that, including the most recent one by OECD called the PIAC, it's great to see that these ideas of just how we even define literacy as beyond being a simple sort of grade level measure or one item test. It's great to see that we're still trying to make use of those kinds of advances in research. But I think the struggle also then is to think about how adult education programs can best serve older adults. And for the most part, public adult education isn't doing much for older people. Thank you.
Thank you. So I see there are 2 more questions, but we're out of time. But we have the reflections panel at the end of the day where we can revisit questions. Thank you.